So today our objectives are clinical presentation of surgical jaundice, that how a patient presents with surgical jaundice. Review of the causes of the jaundice, pathophysiology, important investigation and the management. So there are three types of jaundice. One is pre-hepatic jaundice, second is hepatic jaundice, and the other is post-hepatic jaundice. What is pre-hepatic jaundice? Anyone? Okay, pre-hepatic jaundice is a jaundice which is formed in the breakdown in the liver. After the breakdown of RBCs, especially in the cases of malaria and spinocytosis, and hepatic jaundice is which is due to the obstruction in the liver, obstruction of bilirubin in the liver. And post-hepatic there are some causes which are distal to the liver which are causing post-hepatic jaundice. So the patient will present with you with a complaint of right hypophobic pain, yellowish discoloration of skin which is progressive, dark color of urine which was not initially present, clay colored stool or white colored stool, itching all over the body, and if the patient is having fever, so we will call it cholangitis. And the patient may also complain of loss of appetite and loss of weight, and loss of weight also indicates and loss of appetite that there is some malignancy and so you can see that the area is yellow and the lymph nodes are also palpated over here. So again, these are the signs that loss of weight which is in malignancy, and patient may have fever in cholangitis, and there is charcoal-striates which includes pain, fever, and jaundice, yellowish discoloration of the skin, Reuter's sound or visual node. Here we can see the visual node. Left vesicular clavicular region. So that node is called visuals, and the sign is called Reuter's sign. And there might be tender in right upper quadrant region. And the Reuter's law. What is the Reuter's law? Anyone? If a patient is having gallstones, so the patient will have pain. But if the patient is having any malignancy, so that obstruction will not cause the pain to the patient. So that is the Reuter's law. And abdominal mass and ascites may also be present. If a patient is having deep jaundice, you can also see bruising, which is due to vitamin K deficiency and deficiency of the vitamins 2, 4, 7, 9, and 10. And visual node is present in the left supraclavicular region, and it is also called Reuter's sign. Okay, you can also differentiate normal urine from the dark colored urine which patient is complaining of. What are the causes of obstructive jaundice? There are many causes of obstructive jaundice, but the foremost is cholelithiasis, that is gallstones, cholangiocarcinoma, carcinoma of the pancreas, biliary restriction, cholangitis, congenital structural defects, polydocal cyst, lymph node enlargement, pancreatitis, parasitic infection, and nephrotrauma. But the most common causes are gallstone. Later on, we see head of pancreas and other causes. There is one classification which is of obstructive jaundice, that is Benjamin classification. Type 1 is in which there is complete obstruction of the full passage, which includes tumor of clear head of pancreas, ligation of the CVD because of some surgery, which includes cholangiocarcinoma and parenchymal liver abscess. The other type is intermittent obstruction. In this, patient might have polydocylithiasis, periapillary tumor, luminal diverticula, polydocylcyst, papilloma of the bile duct, intrabiliary parasites, and hemophilium. This is the endoscopic view of periapillary tumor to be differentiated over there. Type 3 is chronic incomplete obstruction. This is present in the strictures of the CVD, whether it is congenital, traumatic, sclerosing, cholangitis, post-radiotherapy, or either it is due to stenosis, biliary enteric anastomosis, cystic fibrosis, chronic pancreatitis, and stenosis of the sphincter of coli. You all have to remember all of these names. It can be asked in mostly by watching. Type 4 is segmental obstruction. It could be due to any trauma, sclerosing cholangitis, intrahepatic stones, and cholangiocarcinoma. What is the pathophysiology of obstructive jaundice? So, obstructive jaundice is a condition in which there is blockage of the flow of bile out of the liver. This results in overflow of bile, and its byproduct into the blood and by excretion from the body, which is incomplete. It can cause hepatic derangement, renal derangement, and it can also cause cardiovascular effect and delayed wound healing due to defective synthesis of collagen. Investigations which are important are, first of all, you will do liver function test, in which we can see that the conjugated bilirubin is increased, and we can also do the urine TR, in which we can detect the urine bilirubin, and ureobilinogen will be absent. Alkaline phosphatase in LFT will be raised, and gamma glutamine transpeptidase will also be increased, and we can also remove 5 nucleotidase, which is raised, and it is specific for carcinoma, and albumin might be decreased in the patient who are having the liver diseases, and PD might be deranged also. Renal function test will be impaired, and CA19-9 is more sensitive for malignancy. If it is positive, we will also do CA levels. Radiology is very important. After the history and examination of the patient, we have to do the investigation, which are blood investigation. When the blood investigation are sensitive and indicative of some pathology and the meaning, then we will proceed with the radiology. So the first radiological investigation is ultrasound abdomen, which is very sensitive for the gallbladder stones, and they can also tell about the size of the ducts, whether stone is present or not, and other ascites and other biliary obstruction also. We can appreciate gallstones in that ultrasound picture, and the shadow, which is posterior shadow, which is also present in this picture. Okay, when we have done ultrasound and it is telling us that there is some pathology. So we can also do endoscopic ultrasound, which is more sensitive in detecting pancreatic and periambular carcinoma. After that, if we have done ultrasound and endoscopic ultrasound, and that endoscopic ultrasound is telling us that there is some pathology present there, we can either do breast cytology or we can take biopsy from there, and later on we have to proceed with CT scan whole abdomen with IV and rectal contrast. It is very sensitive, and CT scanning is also done in pancreatic protocol also when we are detecting some pancreatic pathology and we want to proceed with surgery. MRCP is also indicative if there is any pathology present, if the patient is telling he or she was having DH LFTs from birth, or they are having any other issue. So MRCP is mostly indicative in the procedure, in the patients in which we have to see out the anatomy of the patient. But if we are clear on ultrasound and endoscopic ultrasound, then we have to proceed with CT scan. We don't have to do all of the investigation in every patient. We have to be selective. PTC is also done in the patient in which the distal ducts are not dilated and only the proximal ducts are visible. So we have to do PTC to relocate where the bile is going, and then we can do the drainage also. But it is also not indicative in every patient. Other investigation include oral cystography, which is very rare in Pakistan. Hydra scan, again it is very rare, and we can also do diagnostic laparoscopy, in which our diagnosis is not clear. We can do this, and tumor markers are CA19-9 and the CA level. But the most sensitive is CA19-9. CA levels are mostly in colonic carcinoma. Then we have to do the obstructive jaundice management. How will we do the management? First of all, we will admit the patient in high dependency care unit or ICU, depending on the patient's vital, but he needs monitoring. First, we will admit, then we will intervene with intravenous administration of 5% dextrocytline. We have to start broad spectrum antibiotic. We have to give IV vitamin K for 3 days, and we have to also see the PD-INR level of the patient, and we will transfuse blood and blood products according to it. And we have to do proper eye starting of the patient. If hypokalemia is present, we need to correct it, and we have to see whether the patient is complaining of so much itching, and itching is present at the trunk region or at the limbs, then we have to add corticosteroid. If there is CA head of pancreas involving or periampullary carcinoma or malignancy of lower third of the CBD, then after optimizing the patient and telling the procedure to the patient, we have to proceed with Whipple resection. What is exactly Whipple resection? Whipple resection is a very complex procedure and it is the most complicated procedure of abdominal surgery. It is done in very big tertiary care unit which have facility of hepatobiliary surgeon also. It includes pancreatic duodenectomy, which includes resection of head and neck of the pancreas, duodenum, distal 4% of the stomach, lower CBD, gallbladder, and upper 10 centimeter of the jejunum, and the regional lymph nodes which are present in there. And we have to reconstruct with gastrojejunostomy. This is one anastomosis. Choledojejunostomy. This is second anastomosis, and pancreatojejunostomy. That is the third anastomosis. So we have to reset all these segments which is present in blue over there, and then we have to do the three anastomosis, and then our procedure is completed. But still the procedure is not finalized, or we cannot say that we have done the complete resection. Complete resection depends upon the histopathology report that we have done the complete resection and the patient is recovering well. If we cannot proceed with Whipple's procedure, or we cannot do any surgery in a patient, then we have to do endoscopic hysterectomy, or we have to pass metallic stairs. In again in CAGB, we have to see if we can resect or not. Resection is how can we tell that we can resect this tumor or not? Anyone? I got a patient in ward and he is having obstructive jaundice, a yellowish discoloration of skin and weight loss and everything. Okay, I have done basic investigation and I have done ultrasound. How can I decide that I can resect this tumor or not? What is the one investigation on which we can decide that this tumor is resectable or not? हमें कैसे पता चलेगा ब्लड वेसल्स इन्वॉल्व में CT scan is that investigation. CT scan is the only investigation जो pancreatic protocol के ऊपर होती है. That will tell कि engagement of superior vena के बाद या जो vessels हैं वो हुए हुए हैं नहीं हैं, और उसकी basis के ऊपर we have to proceed with the surgery. अगर CT scan में there is no involvement, then we will proceed. अगर there is involvement around 80 to 90% involvement है, we cannot proceed with surgery. उन patient के अंदर we have to pass metallic stairs. इसके अलावा CAGB है, उसमें भी वही है कि फर्स्ट वी हैव टू सी रिसेक्शन हम कर सकते हैं या नहीं कर सकते. वी हैव टू सी दैट रिसेक्शन ऑन CT scan. Again, if with polytocosis, polytocosis is resectable, we can do polytocosis or anastomosis. Again, cholangiocarcinoma, periampullary carcinoma, CAGB, all have the same management. All have same management. We have to do the same basic investigation, same radiological investigation, and we have to see whether it is resectable or not. If it is resectable, we will proceed with it, but we will see that if the bile ducts are involved, we have to remove that. If there is partial liver involved, we can resect it. Liver procedure, I have told you about it. And if the tumor is not resectable, then we have to pass the metallic stent. And even after passing the metallic stent, the biliary drainage is not possible, then we have to proceed with PTC. Polydomonic acid is a simple thing that stones are present in CBD. We can do ERCB and stenting. Later on, we can proceed with that. This is the image of ERCB, how the ampulla is calibrated, and we can go there. This picture is telling about how we can calibrate and stand testing place over there. If there are restrictions present either due to surgery or the patient is having congenital structure, then first we will do ERCP and stenting. If that ERCP has failed, then we have to proceed with Roux 5 cholecystectomy or hepatojejunostomy. Hepatojejunostomy is the gold standard for the biliary structure. And again, stenosis of the sphincter of Roux, we have to do ERCP and